Good morning, everyone, and welcome to the William J. Neff Symposium held virtually through the Bucks County Community College. This is our 17th annual symposium. And if 17 years ago someone had said to me, there's good news and bad news, Kathy. The good news is we're going to be doing this for at least 17 years. The bad news is the 17th year you're going to do it virtually. There's going to be a pandemic. So who would have thunk that? I would never have thunk that. But I do appreciate all the efforts and assistance that we have gotten from everyone to take this from an in-person symposium to something that we're doing virtually. So I want to welcome all of you. I am Kathy Bennett. I am the director of the Bucks County Area Agency on Aging, and it is my honor to be the person to help things get started this morning. I do believe we do have some virtual housekeeping kinds of things to take care of. And I also want to introduce you to some very important and honored guests. But there's a couple of other things I want to go over first. So first of all, I know that this is a very different kind of way that we're doing things. I would ask that you be patient with us as we're trying this, and hopefully we won't have any glitches. I know I just ruined it and jinxed it for everybody, but hopefully we won't have any glitches, but please be patient with us if we do. And it's really difficult because we're not going to get to network with one another like we usually do. I can't even see anyone other than some of the honored guests that are here that I'm so happy to see, but I do believe you're out there breathing and taking in all this great information. And so I really am very grateful that you are here today and sharing all this critical and important knowledge for the work that we do. So thank you for being here. We have named this the William J. Neff Symposium, and there's a reason for that. So I think we tend to sort of not take into account or not give full due or understanding to everyone why it is named that. So I just want to take 1 second to talk a little bit about Mr. Neff. This was from, first of all, there's the person and the case. And I want to talk a minute about the person. And this came from his obituary from the year 2000. William J. Neff, age 83, was a highly decorated veteran of World War II. He died in 2000 of complications associated with Alzheimer's disease at the Altera Wynwood Nursing Facility in Lower Makefield Township. Mr. Neff, who grew up in the Logan section of Philadelphia, had been a longtime resident of Northeast Philadelphia. After being drafted into the Army in 1943, Mr. Neff saw combat as a cannoneer in Italy, southern France, Germany, and Central Europe. He earned 7 campaign ribbons and 5 battle stars, 2 silver stars, 3 bronze stars, a Purple Heart, a Presidential Unit Citation, and the Croix de Guerre from the French government, among other medals. He was discharged with the rank of private in December of 1945, and in civilian life, he was a shop maintenance mechanic who worked for various manufacturers in the region. Mr. Neff had a wife who preceded him in death the year before and has children, grandchildren, and great-grandchildren. So that's Mr. Neff, the person. I don't know if all of you were aware of his honorable past and the work and the accommodations that he did in his life. But let's just take a little bit more look at the case. In September 2000, William Neff, an 83-year-old man with Alzheimer's disease, residing at a local Bucks County personal care home, died as a result of 5 broken ribs and a punctured lung. In 2003, a healthcare provider at the facility was charged with his murder and neglect of a care-dependent person. In addition, the administrator of the facility, the director of nursing, a resident assistant, and a hospice nurse were criminally charged. It came out of this case that we developed the Bucks County Crimes Against Older Adults Task Force, and we were focusing on preventing future incidences like Mr. Neff and to do whatever we could to help seniors who are in abusive situations. We began the task force in 2003 to more actively and effectively coordinate what we could with multiple agencies to assist at-risk seniors in Bucks County. Our partners have been and continue to be the Bucks County District Attorney's Office, law enforcement, the Bucks County Area Agency on Aging, Consumer Protection of Bucks County, Network of Victim Assistance, Bucks County Register of Wills, and we've added more people and organizations as time has gone on, such as senior law, representatives from banks, healthcare systems, and others. We continue to meet to regularly review cases and do what we can for seniors who are in abusive situations. But it all started because of that heinous crime against Mr. Neff, and it's definitely something we don't want to see ever happen again. We are honored today to have Denise Service, Mr. Neff's granddaughter, attending the conference, and I want to thank her and her family for allowing us to remember her grandfather and honor his memory through this symposium. So thank you, Denise, and thank you to your family. You are always in our minds and our hearts. Let me now introduce you to Dr. Stephanie Shanblatt. Dr. Shanblatt is the Bucks County Community College president. We could not do this without the assistance of the Bucks County Community College. For 17 years, we've done it through with their assistance and their auspices. And I just also have to take a second to thank Damon Honeycutt, who's your IT person, and Janet Baker, who has always been very assistive to us in this from the community college. But Dr. Shanblatt, thank you so much, and we appreciate you being here this morning. Oh, you're muted.
All right, now I can talk and you might be able to hear me. Good morning, everyone, and welcome to the Neff Symposium. I want to thank Commissioner Marseglia and District Attorney Weintraub for their ongoing support for this event. I know that it started before either of you were in your current roles, but you have certainly made sure that it has continued on. I'm certainly pleased that the college is able to host this event again for the 17th straight year, and that we've been able to provide, I will call it a new venue for you to hold the event. And yes, Damon is a wonder. So we appreciate him every day that he helps us do things. It's important. It's been such, I'm sure others will speak to this, but I know it's been such a challenging year for those in healthcare, and especially those taking care of our elders. I know last spring in particular was so difficult for so many. I hope you create some space today to share a little bit, to make some connections, to learn to help each other as well as help those that are in your care. I just want to thank all of the attendees today for the work that you do every single day, and to remind you to take care of yourselves and each other. It's important during this time. It's hopefully you'll learn some things today. There'll be some moments, I hope, where you can laugh and enjoy each other's company and the collegiality of a conference, even though we're not together. But use the chat, find ways to connect. Oh, I guess it's on YouTube, so you can't chat. But anyway, take care of yourselves. Thank you again for being here, right? We're all here, we're all listening, we're all learning together. So I hope you have a very productive day, and thank you.
Thank you, Dr. Shanblatt. We really do, again, appreciate everything that the community college has done, and for your leadership and support. We greatly appreciate it, so thank you. I'd also like to introduce our Bucks County District Attorney, Matt Weintraub. The DA's office has been critical in being a partner with us in the Crimes Against Older Adults Task Force and in pulling together this symposium. And so we're very grateful for his support, his many staff who are supportive, and I will now pass it over to you, Mr. Weintraub.
Thank you, Kathy. Good morning, everybody. Diane, Stephanie. That's the longest I think I've ever been muted. That's a record. So my goal with these formats is to try to have one takeaway, try to learn one new thing, and make one new connection. And although it's not ideal because we don't get free lunch today, at least we didn't have to drive anywhere. And I have to admit, I'm getting somewhat used to that a little bit. But to talk about this on a more serious note, I think that the pandemic has really made seniors more vulnerable, certainly because they have to be concerned about this new health risk. But even more behind the scenes, or slightly more insidious, is they're more vulnerable to abuse and neglect because of the isolation that they may be imposing on themselves, or that they may be experiencing even though they don't wish it. And that means that they're having less contact with their caregivers, their loved ones, and their trustees. So we need to, everybody that's participating today needs to reach out to be more proactive, to try to make sure that we care for these seniors, for one of our most precious resources. And to just give you an example, a bunch of us brainstormed pretty recently and took our act on the road, so to speak. We teamed up with Mike Bannon from Bucks County Consumer Protection, Kathy Bennett from Area Agency on Aging, Brendan Corballis from Senior Law, Kate Kohler from my office, and we created a traveling roadshow, a virtual traveling roadshow, because we knew that the seniors, to try to fill a gap, the seniors are so conditioned to going to these senior forums. I know a lot of it's for the swag, but also they learn a lot of information. So we recreated that experience virtually, minus the swag, and have done this so on cable TV and local venues and some of our townships, and hope to continue that. So I think that my message, other than one of thanks to all of our stakeholders here, 17 years, that's a pretty incredible legacy for Mr. Neff, 17 and counting, is that we really need to reach seniors any way we can. We need to be even more proactive as opposed to reactive, because these seniors may be inaccessible otherwise. I know that we're going to have a great program today. I expect everybody to learn a lot, but if you get one takeaway and one new connection, that's great, and even some good reinforcement. And the message really is, let's keep our seniors safe. Thank you, Kathy.
Thank you so much, Matt. Really do appreciate it. And we're going to mute you again, Matt. See how long it lasts this time. No kidding. I also want a very short amount of time. I also want to introduce now and thank her support for Commissioner Diane Marseglia. It has been, I think, Diane, you've come to just about every Neff, I'm not sure, but quite a number of them. And we really do appreciate the support of the commissioners, their acknowledgement again, and of course, their care about seniors in our community, and those of us who are taking care of them and trying to do what we can to assist them. So thank you, Commissioner, and we appreciate you being here this morning.
Thank you, and thank you for holding this every year. You know, this has been a very difficult year. As one who has a parent in a long-term care facility, I am just acutely aware of the patience and fortitude that those who work with the elderly have had to face the past 7 or 8 months, you know, not being able to see my mother even one time and being reliant on other people. It's a tough time for everybody. But, you know, I'm also grateful for this conference because it does address the issues of crimes to the elderly. My mother entered Neshaminy Manor in 2012, and to this day, I am still getting magazines and greeting cards from places that she gave money to, trying to get more money from my mother. And in her right mind, she never would have given to some of the places that she gave to. So you don't even see when it's happening sometime, and the long-term damage from that. And as a commissioner, you know, I get the calls all the time from either someone who's calling and they may have some dementia, but they think their family is stealing from them, or you get the calls from a family member who think that a caregiver is hurting their family. So it's important that we all stay aware, and I'm so grateful that the Area Agency on Aging and the District Attorney's Office has always partnered on this. I'm also grateful that Dr. Chamblin has given the community college and Damien to help us today to be able to have the Neff Symposium. But I also want to make sure that I say how grateful I am for everybody who's out there watching this and being a part of this symposium. I know that the elderly are not always the easiest population to work with, but if you are in this room, then you see them as a delight and a gift. You have the respect for our aging parents and that light touch that is really necessary to do this sacred kind of work. And I also teach a course at the college here in social work. And interestingly enough, I have my students buy the social work dictionary for this class, and they have to pick a random word every week and they discuss it. And ironically, it was due Sunday night. This week's word was gerontophobia from one of my students, a fear of getting old or of old people. And I saw that word come up and I paid particular attention because of the Neff Symposium. But it was so touching to me that how many of the students said something about how upset they were that anybody would even have that, any kind of phobia about the elderly. And that 3 of them specifically said they were looking forward to working with the elderly as social workers. And I thought, how amazing is this world that there's always somebody to fill a need. And I am grateful to be able to say that there are more people in the future to fill that need. So have a great conference, and thank you all again for having it. And I'm grateful to be here with you. Thanks.
Thank you, Commissioner. Great words, really do appreciate it. So now I have some virtual housekeeping for all of you. So please note, all of you should have gotten, and this is how you are here today, an email that gives you links to the various workshops, etc. So please note that all of our breakout sessions will be viewed on Blue Jeans. And if you haven't clicked on one of those links yet, you might want to do that prior to when we start the workshops later this morning, just to make sure that you have that connectivity to get to that. Each breakout session has a maximum attendance. Unfortunately, even virtually, there's a limit to how many folks we can have in each workshop. So it's limited to 100 people. So if you find you're not able to join a particular session, please click on a link to another session. We should have ample room for all of you, but at the very least, if there's technology problems, please know that everything is being recorded, will be uploaded onto the Bucks County Community College website, and so that you'll be able to view all of these things, all the various sessions. So even if for some reason you're having some difficulty with the technology and you are taking this conference for CEUs and you want to make sure that you hit every session, you will be able to do that through the recording. So just want to make sure, in case you're having any kind of difficulty, that we have this sort of backup system in place for that. The PowerPoints for all the sessions will also be available on the website for viewing. This will probably take a week or so to get everything downloaded, so please be patient, but please know that it will be available. We do ask that attendees keep themselves muted during the symposium. I know that's hard for some, and that your video is kept shut off. We want to definitely thank all of our various sponsors who make it possible for us to offer this symposium free of charge. We have never charged anyone for attending this symposium, and that's because of all our wonderful sponsors. If during your lunch or some of the breaks you can, in your schedule, you can visit the sponsor page. There's short videos and clips from each of the various sponsors, which I looked at last night, are really very well done. So if you have a minute to take a look at those, that would be really great. And again, that link to those videos is on the email that we sent out to you. Also on the event email, you'll find an evaluation questionnaire, which we ask that you complete at the end of the conference. This is definitely necessary for those of you that, excuse me, want to receive continuing ed credits for today's conference. And it also really does provide us with valuable feedback. We go through every evaluation and look for areas of ways that we can improve, topics that would be of interest to individuals. There's always something that we get from the evaluations. And so I really do encourage you to fill those out and help us to improve number 18 conference. We will try to follow the schedule as tightly as possible today. So just want you to be aware of the start and end dates as well. And lastly, certificates will be emailed after the conference. So using the email address you provided us at the time that you registered. So please know that that's how you will get your certificate. And again, it'll take a couple of weeks to do that. All right, that's all I have as far as virtual housekeeping. I wish my home were this easily to do virtual housekeeping, but it's not. Okay. So what I'd like to do now is introduce our guest speaker. Today we have as our speaker, Professor Hoffman. He is doing a session for us on, does the long-term care facility enforcement system protect residents from abuse and neglect, which is such a timely thing to talk about again, as part of the Neff Symposium, but also as part of what everyone has concerns about regarding COVID. I just want to point out that Professor Hoffman is a practice professor of law at the Thomas R. Klein School of Law, Drexel University, and president of David Hoffman and Associates PC, a national consulting firm he established in 2005 that has expertise in law, policy, corporate compliance, regulations that apply to healthcare delivery, patient safety, long-term care, and fraud. This firm has helped some of the largest of the nation's healthcare providers adhere to regulatory practices. It has also consulted with the U.S. Department of Justice regarding failure of care in institutional settings, and has been appointed by state and federal authorities to serve as a monitor for long-term care facilities that come under the scrutiny for prior violations. Professor Hoffman has received the Director's Award from the U.S. Department of Executive Office for United States Attorneys in recognition for his work to protect elderly from abuse and neglect, as well as receiving the U.S. Department of Health and Human Services Inspector General's Integrity Award. Prior to joining the U.S. Attorney's Office, Professor Hoffman served in the Governor's Office of General Counsel and, something close to my heart, as Chief Counsel for the Pennsylvania Department on Aging. Elected as Fellow for the College of Physicians of Philadelphia, Professor Hoffman is a former president and current board member of the Eastern Pennsylvania Geriatric Society. Professor Hoffman, we are so fortunate to have you here. Thank you for your time, and we look forward to your presentation.
Thanks, Kathy, and good morning, everyone. And thank you to the Bucks County Crimes Against Older Adults Task Force for inviting me to again deliver a keynote address at this important symposium. Yes, I spoke in 2012 about the Older Adults Protective Services Act. And certainly a lot has changed in 8 years. And one of the most troubling changes is the fact that I all too often now meet the definition of an older adult in need of protective services, which is not good. So anyway, I also want to thank Mr. Neff's family for attending and say that he is in our thoughts as we move forward for this discussion. In any event, I am thrilled to be here today to share with you my perspectives on the changing nursing home population and whether the regulatory system overseeing nursing homes is adequately ensuring that abuse and neglect is reported, investigated, and addressed. I did not envision a pandemic when I accepted the invitation to speak to all of you today. And while my talk is not COVID specific, I cannot ignore, and we cannot ignore, the harm that has befallen our nursing home residents and committed staff. While I am deeply saddened by the extensive loss of life and the enormous emotional toll that it has taken on loved ones all over the country, I am also candidly livid. This virus has hit home with me as a result of losing a family member who was diagnosed ping-pong back and forth from his nursing home and subsequently passed away. He died without family by his side, and his funeral was attended via Zoom. This virus is real and it is unrelenting. But while there are a number of reasons for this unnecessary loss of our nursing home residents and staff, there is one glaring failure that in my mind is at the top of the list. I cannot tell you how much time I spent on the phone as a practicing attorney attempting to obtain needed PPE for my clients, only to be met with robber barons masquerading as medical equipment providers, price gouging masks, gowns, and shoe coverings. One provider had to have his supplier ship PPE to Canada and then have trucks cross over the border at lightly guarded areas to get PPE, not guns, not drugs, protective equipment to our needed staff. The notion that there is plenty of PPE even today to go around all the facilities is flawed and not true. I just taught a nursing home administrators class last week, and I've heard from many of my students working in nursing homes currently that they were still short on PPE. The failure to create a national supply chain of PPE was and is unconscionable and will continue to cause catastrophic harm to thousands of people. My topic today includes a discussion of the changing population in nursing homes, but never did I imagine that resident deaths due to COVID-19 and a loss of new admissions would lead to a resident reduction of well over 100,000 in number. So does the long-term care facility enforcement system protect residents from abuse and neglect? Let's start with this. It should and it must. So let's talk a little bit, let me get my slides to move, about some definitions. Oh, sorry. First of all, as we're familiar, in federal law and federal regulation, abuse and neglect are defined terms. I thought it's important that we all start on the same page. Abuse is the willful infliction of injury, unreasonable confinement, intimidation, punishment with resulting physical harm, pain, or mental anguish. It includes a deprivation by an individual, including a caretaker, of goods or services that are necessary to attain or maintain physical, mental, and psychosocial well-being. Mr. Neff suffered abuse, and it was unconscionable and outrageous. And criminal charges were absolutely appropriate in that matter. But interestingly enough, abuse includes mental abuse, facilitated or enabled through the use of technology. I remain amazed of what people post on YouTube or post anywhere on social media. I don't go on social media. I guess I'm not that interesting a person, but it is truly amazing, including outrageous acts of abuse. Even earlier this year, of a younger individual in a nursing home abusing an older adult that appears on YouTube. Outrageous, just outrageous. The second prong that we'll be discussing is neglect. And neglect is the failure of the facility, its employees or service providers, to provide goods and services to a resident that are necessary to avoid physical harm, pain, mental anguish, or emotional distress. And obviously the big difference is intent, because when we look at abuse, we have willful infliction. This idea, if I put my hand, ball my hand up in a fist and haul off and hit somebody, that's willful. That's not a mistake. But neglect is a simple failure. It's a very broad definition. And so we want to apply neglect to those appropriate cases, because not every failure constitutes neglectful conduct. The coronavirus has exposed neglectful conduct by both regulators and the industry. Lack of consistent, thoughtful enforcement of the nursing home regulations by CMS and state survey agencies has created a toxic environment in which reasoned approaches to protecting the resident health and safety are subverted by misguided regulatory interpretations. Additionally, providers engage in neglectful conduct, since a fully functioning infection control program would have mitigated the death toll in nursing homes. Regulators should review whether facility personnel were practicing disaster drills that plan for isolation, education of staff, evaluation of PPE need, convening planning meetings with the mandated skilled infection preventionists and infection control team, and of course, anticipating the enhanced challenges associated with staffing the facility during a time of great stress. We will get through this situation only by working collaboratively to protect the residents and heroic staff delivering care to them. But don't get me wrong, some providers should and must be prosecuted to the fullest extent of the law for their callous response to the mandate for an effective infection prevention and control program. So what does the nursing home population data tell us? This data is from 2014. I searched around to try to get new data. I did not see any. And so this is what we have. Almost 8% of nursing home residents were 95 years of age or older. Almost 34% were 85 to 94 years old. 26% were 75 to 84, 16 and a half, 65 to 74, and about 15.5% were under age 65. I am convinced that that number, the under age 65 crowd, is significantly higher as we sit here today in 2020. It's been my experience that this younger population and younger residents have mental health diagnoses, and that this number is up dramatically. That homeless individuals with underlying medical issues, such as endocarditis, are discharged from the hospital to the nursing home for IV antibiotic treatment and remain, and sometimes even turn into long-term residents. So what do they bring to the table? They bring to the table behavioral health concerns and the need for behavioral health services. And so we have a population now residing in nursing homes of significant people with cognitive impairments, at the same time residing with individuals with behavioral health issues. Those two populations are not a good mix. I don't think anyone would dispute that. And so the question now is, are all residents being protected, given that change in population? And this challenges associated with this population go more than just medical issues. As I said, it is behavioral in nature, something that only recently, within the last few years, was recognized from a regulatory perspective in the nursing home regulations. And so in 2016, the regulatory framework was changed to include behavioral health services. Each resident must receive and the facility must provide the necessary behavioral health care and services to attain or maintain the highest practicable physical, mental, and psychosocial well-being in accordance with a comprehensive assessment and plan of care. Behavioral health encompasses a resident's whole emotional and mental well-being, which includes but is not limited to the prevention and treatment of mental and substance use disorders. This is the overarching behavioral requirement. Comprehensive assessment and plan of care. We know, for those of us who have been involved in this industry for years, that a comprehensive assessment and plan of care has to be done from the minute a resident arrives at the facility. We have to be fully prepared to meet their needs. We have to really assess effectively what their needs are from a resident perspective and develop an appropriate plan of care. But if we don't have the expertise to address these residents from an assessment and care planning approach, then we're behind the 8 ball in the beginning of the stay. The facility must also have sufficient staff who provide direct services to residents with the appropriate competencies and skill sets to provide nursing and related services to assure the highest practicable level that we've talked about. These competencies and skill sets include, but are not limited to, knowledge of appropriate training and supervision for caring for residents with mental and psychosocial disorders, history of trauma, post-traumatic stress disorder. All of these things that up until recently have not been the focus of our nursing home staff. And of course, critically implementing non-pharmacological interventions. We can't just chemically restrain those with behavior issues. And so what do the regulators say? Well, before we get to that, at the end of the day, the regulators say providing behavioral health care and services is an integral part of the person-centered environment. and it requires an interdisciplinary approach to care with qualified staff. Again, training, education, expertise, and competency. And that there's individualized approaches to care, including direct care and activities. Because obviously activities for a younger person with behavioral issues is very different than activities for someone who's a long-term, older adult, cognitively impaired. Very different kinds of activities are appropriate. And so you have to meet the individualized need. And so the investigation from a regulatory perspective, when reviewing, again, from the surveyor world, review care plans and assessments, review minimum data sets to make sure there was an understanding of what this resident needs, make observations as to care delivery, and interview staff. Corroborate the information obtained and any concerns noted during the survey. And you build your investigation. And Matt knows all about building an investigation, obviously. You're trying to evaluate whether care is actual and services are actually being delivered. It is an investigation of concerns related to behavioral health. So with that as a regulatory framework, we next moved to a 2019 study, which talked about the association between high proportions of seriously mentally ill nursing home residents and the quality of resident care. It appeared written by McGarry et al. In the Journal of American Geriatric Society from 2019. And they define the population as those who have high proportion as a nursing home with at least 10% of the population having a serious mental illness, SMI diagnosis, schizophrenia or bipolar disorder. 10% is the threshold. And it was interesting to learn that it was estimated that annual number of individuals with mental illness is roughly 10 times the number treated in psychiatric hospitals. We are treating roughly 10 times the number treated in psychiatric hospitals in nursing homes. Pretty astounding. The study found that the admission to a high SMA nursing home increased the risk of feeding tubes for individuals, with SMI, and increased risk of hospitalization, catheter, and feeding tubes for individuals without SMI. So what is this objective? We're trying to associate quality of care delivered in nursing homes to residents with or without serious mental illness and the proportion of nursing home residents with SMI. These are very troubling findings. Increased risk of feeding tube for individuals with SMI means that something has gone wrong, typically in terms of clinical problems. Increased risk of hospitalization for residents who don't even have SMI. So why is that the case? What is going on in that regard? We also know that residents with SMI end up in lower quality facilities, and quality may be defined as lower star ratings by CMS, higher incidence of bad outcomes. And the reason behind this is that there's a lack of development of expertise. Remember the regulatory framework I told you about, that we have to have expertise in the building, that these residents are resource intensive. And so at the end of the day, what is going on here? The study found that admission was associated with roughly 70% increase of having a feeding tube, worse outcomes, like I mentioned, in terms of hospitalization. And so at the end of the day, what is going on? What is our concern from an abuse and neglect perspective? And is our regulatory system geared up to address this issue? Caring for individuals with SMI is resource intensive. There are more hours of direct care, more likely to become long-term care residents, and they need specialized services associated with their care, namely psychiatrists. And the study conclusion was admission to nursing homes with high concentrations of residents with SMI is associated with worse outcomes for both residents with and without SMI. I tell you this because I want us to be advocates. I want us to respond to this now. And so who are the experts in the facility? Years ago, I was monitoring a facility in Vermont pursuant to a settlement agreement entered into by a nursing home and the Attorney General's office. And I learned of a case where it became clear that the only intervention that was being performed by staff was chemical restraint. Chemical restraint until the resident's demise. They so snowed this resident to deal with her outbursts that it caused her demise. Totally unacceptable, obviously. The facility's defense was that it could not obtain psychiatric and psychological services. Suffice it to say that went nowhere as a defense. Additionally, in Louisiana, as part of our monitoring project pursuant to a corporate integrity agreement, the facility had a behavioral health unit without any training being offered on geropsychiatry. In California recently, residents, as part of another monitoring project, residents with behavioral issues were admitted at all hours of the night. 9, 10, or even later were being discharged from the hospital. And the facility then was left with moving people around. And I came to learn of a phrase called floaters. What are floaters? Residents that didn't have a room. They were placed in the rehab room. Unbelievable, unbelievable. But because there were behavioral issues associated with these residents, they were moving people around. At 10, 11 o'clock at night, it was like residents became a party to a shell game, which is no laughing matter. But in Massachusetts, again in a monitoring experience, there's a dedicated individual who was working at the facility on a daily basis and is working with staff to educate. And they have a significant population of people with SMI, and they're addressing it and they're committed to it. And so I've seen the good and the bad. But at the end of the day, what must we do to avoid abuse and neglect for not only residents with SMI, but those without, resulting from these populations mixing together? Well, clearly, as I've mentioned, staff lack the skills necessary to meet the needs of the residents. There's a huge disconnect between staff and the residents. The traditional training on wound care, falls, those kinds of things for a geriatric resident do not match up with the need for de-escalation for behavior or treatment for complex mental health issues. Attention given to these complex mental health issues inevitably leads to less care for the geriatric population. There is a fundamental lack of training and education coupled with limited resources and payments. And there's a payment angle to this as well, thereby creating a perfect storm of risk for abuse and neglect. We must advocate for additional training and resources, including creation of psych techs to educate and assist CNAs in the delivery of care. There must be active psychiatric oversight, since the nursing home skill sets are currently just not in existence. So we must educate and provide needed resources, or we will see the numbers of abuse and neglect cases increase substantially as the nursing home population changes. So our next phase of our discussion will turn to more directly answering the question, does our regulatory system protect against abuse and neglect? And I thought this was a good summation of where we are today, that from Miller and Moore, balancing regulatory controls and incentives towards smarter and more transparent oversight and long-term care. Government oversight of long-term care involves inspections of patients' records, limited observations of patients and care practices, reviews of policies and procedures, and distribution of publicly available information. Although many providers bemoan the stifling consequences of excessive regulation, oversight in this area remains a highly legitimate endeavor for the public. though the public has limited trust in the existing regulatory regime. This distrust stems from many sources, not least of which includes considerable variation, both within and across states, in the way government oversight occurs. Reforming the current regulatory structure requires that we regulate smarter and more consistently. This means improving and maximizing use of the data already being collected, but it also means explicitly rationalizing the regulator's responsibility to review performance and apply sanctions when necessary. Oversight should more closely resemble consultancy, with regulators sharing information with providers about how to improve quality. Ideally, there needs to be an iterative process in which state inspectors identify performance problems, and the nation's quality improvement organization then help providers design quality improvement interventions to ameliorate the problems identified. Well, this debate has raged for years. What is the role of the regulator? Is it enforcement or is it consultancy? Where should we go? Now, if we were in person together, we would be interacting at this point. And this is what I miss as part of our discussion. Because even as a keynote speaker, I like to engage, and we will have questions at the end, I promise you. And I will hope to answer your questions. But there are different approaches to regulation. It has to be reasonable, it has to be appropriate. But look at this population that we're trying to regulate. Nursing homes are probably the most regulated industry in the country. And why is that? It's because of the frail and vulnerable population that we are seeking to protect. And we have seen over the last several months just how vulnerable this population is. So what do we do? How do we regulate this industry? Because I guarantee you, advocates on behalf of residents and the industry are both very unhappy with the current system. No one is happy with the system. Advocates say they're not enforced enough, they're not regulated enough, they're not hammered enough, and the industry says fines are punitive. This is just weaponized the program, and it's outrageous, it's unfair, and it doesn't assist in improving care. I was the first one who started the Department of Justice Failure of Care Initiative in 1996 as a result of a gentleman named William Young, who was hospitalized with 28 pressure ulcers, some carved out to the bone. You could see his tendon in his right shoulder. And when you get to gross neglect, when you get to gross negligence, when you have care that's tantamount to no care at all, then all options for remedial actions are on the table: regulatory, criminal, federal, civil, from my perspective. Because this is a vulnerable population. And there are some in this industry who choose profits over care. And they need to be removed from this industry. So yes, I am for aggressive enforcement when it's appropriate. And so, but I've also seen immediate jeopardy citations that go on for months without resolution. Now, how can a facility be in immediate jeopardy for months without resolution of the matter? It makes no sense. By its very definition, it's an immediate jeopardy. So there are things that go back and forth, arguments that go back and forth, but it's not a system that is working as well and is as effective as it needs to be. The regulators, from my perspective, must be focused on this vulnerable population. And I think they should more often issue directed plans of correction and tell providers what to do. Because I do come from the belief that, but for a very small portion of nursing home providers, that most want to do the right thing. And if they've been cited for deficiencies, why are we relying on them to fix it? We should tell them what needs to be done and monitor to make sure that has in fact occurred. Tell them. It shouldn't be a great secret. It is amazing to me that the falls in nursing homes are still an issue. They're the number one reason for regulatory engagement, lawsuits. And where are people falling? They're typically falling in their room. And why are they falling? Going to and from the bathroom. And so we know why things are occurring, and yet they're not being fixed. And at the end of the day, a lot of it is about staffing. And we'll talk a little bit about staffing later on. But I think it's important that from an abuse and neglect perspective, we tell providers how they're going to fix it. And if you can't fix it, then we're going to impose an aggressive fashion. In California, falsification of records has been a real problem in a recent monitored case. But I think falsification of records is a huge issue in this industry. And it's really something that has to be aggressively pursued from a regulatory perspective. The county went into a facility that we were monitoring. We hadn't been in there since February, obviously, because of COVID-19. And the regulators went in and observed a med pass. Medications were not on the cart, yet documentation showed dispensing of the medication. I'll cut to the chase. Hundreds of doses of medication were not administered, could not possibly have been administered because they weren't in the building, and yet they were signed off as having been delivered. HIV medications, medications to treat diabetes. And so what does this suggest? It suggests a widespread and profound culture of conscious, reckless disregard for resident health and safety, as well as a total indifference to the duty of candor, accuracy, and honesty. It appears as though the nurses had become completely accustomed to falsifying records on a daily basis, and no one reported anything. Now, from a regulatory perspective, the facility was cited for immediate jeopardy, and correctly so. But it was interesting because at the end of the day, immediate jeopardy was cleared after 10, 11 days, which was surprising for a number of different reasons. But in the plan of correction, the provider said, what would you do with these nurses? I mean, that was, from my perspective, I have zero tolerance for falsification of records. If a nurse falsifies a record and thinks so that that's okay, that they are too high risk to stay in my organization, I'm going to report them to the nursing board. But in this case, in the plan of correction, the provider said, we gave all these nurses who day after day falsified hundreds of doses of medication dispensing. We gave them a final warning, and next time we're going to report them, we'll terminate them and report them to the board. Now that did not sit well with me at all. And as part of a monitoring team, we thought it was outrageous as a regulatory response. Because medical records mean something, they're essential. And yet that was accepted as a plan of correction, not to sanction those who did it. So as we turn to the third component of my talk today, I wanted to talk a little bit about recent HHS OIG Office of Audit Services report from August 2020 regarding abuse and neglect reporting. And so I could start with just the cover. I don't know if you can see that, sorry. I'll read it to you. New Jersey did not ensure that incidents of potential abuse or neglect of Medicaid beneficiaries residing in nursing facilities were always properly investigated and reported. And so this struck me as very interesting because at the end of the day, it has to be reported in order to be investigated. We know about the Elder Justice Act that requires the reporting of reasonable suspicion of a crime. And if there's serious bodily injury within 2 hours and within 24 hours, if there's a crime that has potentially been committed. We know that. We know there's mandatory reporting to law enforcement in that regard. Whether that's actually occurring and whether law enforcement is actually responding is another discussion. But what I found interesting in this matter was that the OIG audit services looked at hospital records and matched up, created a methodology that looked at hospitalizations that basically they selected diagnosis codes for Medicaid beneficiaries who resided in nursing homes and who were transferred to ERs or other hospital settings. And the focus was on diagnosis codes that allegedly had a risk of resulting from abuse or neglect. So they ended up with a stratified sample of 103. The obvious diagnosis codes were adult sexual abuse confirmed with initial encounter of exam, and observation following alleged adult rape, encounter for examination and observation alleged adult physical abuse. So there were 3 claims in that regard. But thereafter, they went with top 3 diagnosis codes used in the review were pneumonitis due to inhalation of food and vomit, aspiration pneumonia, pressure ulcer of sacral region, stage 4, and an unspecified injury of head. And the audit services team worked with state agencies to evaluate these cases through chart review. And so it was interesting because aspiration pneumonia is not a typical indicator of abuse or neglect. It's a consequence of neurologic diseases, dementias, Parkinson's, cerebral vascular accidents. So it was interesting that that was selected as an area to focus. Sacral wounds, however, pressure injuries, stage 4, that has been historically something that has triggered abuse and neglect, especially neglect issues. An unspecified injury of head made sense as well. So what the bottom line was, through these audit findings, 5 claims were not reported to the state based on, let me give you an example of what the 5 claims were. So these were not reported to the state agency at all. Number 1, in one incident, a Medicaid beneficiary was thrown from her bed inside her room by another nursing facility resident, according to the notes provided by the nursing facility. Beneficiary was sent to the hospital emergency department for hip pain. This was never reported to the state agency, wasn't reported to law enforcement. And resident-to-resident abuse has historically been an interesting challenge from both a reporting, at regulatory, and also law enforcement perspective. Providers sort of preempt reporting saying, well, there's cognitive impairment, so it doesn't really fit a crime. Or in the alternative, we're not going to report this again because it was resident-to-resident abuse. But we know that's not the case, and we know things should be reported. The second incident was a Medicaid beneficiary was found on a hallway floor bleeding from the top of her head. According to the notes provided by the nursing facility, she was confused and unable to explain how she ended up on the hallway floor. Okay. Again, never reported to the state survey agency at all. And so I found that very interesting that using hospital records and then figuring out, at some point she ended up from a hospital perspective being admitted, or at least evaluated. Why wasn't that case reported? Now, the other kind of case that they looked into were cases where they didn't have documentation. And I know I sound like a broken record, but documentation is critically important in nursing homes. And so there were records that were not provided or insufficient to determine whether an incident should have been investigated and reported. And there were 14 claims in that case. So a Medicaid beneficiary with a history of dementia was transferred to a hospital emergency department after a fall. The associated nursing facility provided no records for the beneficiary despite multiple requests. They just don't have any records. They didn't cooperate. And the other case was the nursing home administered a medication designed to rapidly reverse opioid overdose at the nursing facility, transferred the resident to a hospital ED. However, nursing records didn't contain documentations what led up to the circumstances where the drug was administered. So I found this was very interesting. And I think this is a fertile ground because I know when I monitor with my team of nurses, we look at recent hospitalizations. I don't have access to hospital records, but we look at why people went out. And the recommendation from the OIG was that we will reinforce guidance to work with the Department of Health in New Jersey, reinforce guidance for ensuring potential incidents of abuse or neglect are reported, and develop additional procedures for its survey site visits, including reviewing nursing facilities records related to hospital transfers for certain beneficiary injuries or conditions that could be the result of potential abuse or neglect. Focus on this from the perspective of the regulator. And so what do we need to do going forward? What should we do? I think, because I want us to take action step, because there are issues. The Pennsylvania Department of Health is currently reviewing its regulations as we speak. Advocate for changes, advocate for reporting, engage the regulators as to how we can best improve our system. Staffing is paramount to ensuring resident safety. Those need to be staffing regulations need to be added because Pennsylvania is woefully low as staffing requirements for long-term care facilities. And the other big piece, and staffing is not just a number. COVID-19 has brought staff together in ways not seen before. And that perhaps is maybe the one good thing coming out of this virus. Teamwork, sense of caring and commitment to one another and performing heroic acts. We don't see people leaving nursing homes having survived like we see people coming out of the hospitals on television. It doesn't diminish the hard work in having them survive this virus in nursing homes. And we are having some success, but we just don't see it. But what would things look like with now COVID pay going forward? What steps will be taken to address how facilities implement their infection and control prevention program? And this ownership, transparency, and accountability must be mandated. This is a tough area. The profit motive in long-term care facilities is deadly. Hedge fund money, multiple LLCs that disguise true ownership. We have to have transparency and accountability as part of our regulatory construct. The public must know who owns and operates and manages nursing homes before they are allowed to come into our state going forward. We cannot allow the market for long-term care services to overwhelm compliance. These are some of the most vulnerable members of our society, and we must protect them. If not, what does that say about us? So in conclusion, the nursing home population is changing, and residents will continue to be at significant risk of abuse and neglect. We must mandate education and competency of staff caring for residents with serious mental illness. And as we've talked about, we must advocate for an oversight system that balances enforcement with consultancy in order to create an effective regulatory system. I thank you again for the invitation to speak with you. You have a great day of breakout sessions. I am open for questions.
Damon, do you know if we have any questions that have come through?
There has not been any.
Okay. So while you were talking, Dr. Hoffman, Mr. Hoffman, I got to thinking about the fact that the role of ageism in all of this. And I don't know if that's something that you've talked much about or thought much about, but my staff certainly have heard me say if what was happening during COVID was in nursing facilities was happening in, for example, children's hospitals, there would have been such an uproar and outcry to make change. And yet, part of it for me is this sense that, oh, well, they're older individuals. And I didn't know if you wanted to just comment on that a little bit.
Kathy, ageism has been an issue for a long time, but I think you're absolutely right. It has really come to the forefront now that there are some who have taken this as if these are the people that it's not as big a deal because they are coming to the end of their lives. And it's outrageous and it's unconscionable and it's not who we are. That's not who we are as a society. I would reject that. I think it is a part of it, and you can dismiss it for a lot of silly reasons. But I am in agreement with you. It is not acceptable as a defense to any of this.
Yeah. Yeah, thank you. I appreciate your comments on that. I also wanted to ask you, folks, unless you ask some questions, I'm just going to keep going here. So, David and I will we'll just have a, tete-a-tete here, I tell you. So I wanted, you talked about geropsychiatrists. I'm sensing there's probably a lack of that, or can you talk about that a little bit, how difficult that is to have that specialty at facilities?
I think it depends, it's sort of the lawyer answer of it depends, which is an answer, but it's very unsatisfying. I think there is a challenge in terms of geropsychiatry throughout the country, and it's a specialty that is, there's certainly a need. And for years, we didn't really address older adult suicide and depression and just sort of how people are reacting. And I think it does contribute to abuse and neglect that drives people into these kind of state. And so, we're lucky in Philadelphia area to have some expertise, but that's not nationally available. So I think that's part of the issue as well. And especially in long-term care facilities, just access. Again, one of the things that could be a positive byproduct is telehealth services. And so facilities should avail themselves of telehealth to include psychiatry services if you can't get somebody in. Now, others say, well, somebody talking through a screen, does that contribute to any kind of illness? I think there's been great success with mental health service provision through telehealth. So there's no excuse now to say, oh, we couldn't find a psychiatrist, or we couldn't find a psychologist or a nurse practitioner with expertise in this. We can.
Excellent point. And one final thought that I had or question has to do with the fact that it just went out of my head. Oh my gosh. I was going to ask you about staffing, but what was the other? I'm so sorry. It went out of my head. And that happens as, you're not the only one getting older as we, going forward. So
thank you.
Just so you know.
You did that for my benefit, Kathy.
I did. Yeah, really. It was nothing on my part. Okay. So we don't have any other questions at this point. And what I do want to say, though, is, David, thank you so much. This has been, my question was, this has been an issue that I've had a lot of concerns about because of the fact that we have more and more individuals with dementias, Alzheimer's going into facilities that have less regulations. So personal care homes that have greater needs. And it is a concern that we've noticed in our work at the Area Agency on Aging with reports of abuse because of the fact that they are not in skilled nursing facilities, they're in personal care homes. And yet because of their cognitive abilities, there's a lot of concerns there. So I guess, do you foresee that there's going to be some outgrowth a little bit more as far as regulations for dementia care facilities?
Well, I think there should be, number one. I think that's a reasonable approach. But I think another way to even look at this is as a consumer protection kind of angle. A lot of these entities say and advertise, send us your individuals who have cognitive impairment. Right. And if they don't meet their needs, that's a consumer protection angle and enforceable by the state attorney general's office and even perhaps on a local level. And so we have to look at our tools in the toolbox to pursue those. I'm all for reasonable enforcement of reasonable regulations. And we tried I was chief counsel back in the day, late 80s, early 90s. And we started down the path. We actually got mobility on the table for personal care homes and put requirements in, but it was a battle. I mean, some legislators own personal care homes. So it was a quite a lift back then. But things haven't changed. But I think we have to look at that regulation as well. And again, advocacy is really important. And this group is unique in that you've come together for now year after year after year, 17 years. I give you guys a lot of credit. I think it's wonderful. It's again, testament to the memory of Mr. Neff. And I think that you should comment on these regulations. You could draw, I know it's tough in Harrisburg these days, but this should not be an issue that divides people along political lines.
Totally agree. Thank you. That was very helpful to get your feedback and thoughts about that. So it is 10:11, and the next sessions begin at 10:30. So that gives folks a good 20 minutes or so to be able to take a break. David, thank you again so much. I found your talk so helpful and inspiring, and you're right. There's more that we could be doing and need to as a combined group. So I appreciate very much you taking the time to present to us and to continue to challenge us to do what we need to do to help seniors. So folks,
thanks so much.
It is now time for a break. Hang on one second. I think there is a chat.
There's one question.
Yeah, there's one question.
Woohoo!
You see, I knew they get tired of me talking. You mentioned PA having a low requirement for staffing. If I got that right, how do we compare with other states? That's a good question.
Yeah, it's a good question. So Pennsylvania under state regs has a 2.7 PPD, patient per day, kind of standard. Estimates say you should be closer to around 4.1 to ensure that the nursing levels are appropriate. So we're not great. And but again, that number is the floor, not the ceiling. Some people treat that as the ceiling, which is inappropriate. So I think, so how are we? We're in the ballpark on the lower end, unfortunately. I mean, I was in Mississippi monitoring, and state regulators hadn't been there for 2 years. So, in terms of a regulatory oversight issue, that's number one, but also to meet staffing. And we were beating on, the reason why I raise that is we were beating on them for staffing. I mean, they were paying nurses aides, CNAs, $7.95 an hour to deliver the toughest job probably anywhere, to serve as a certified nurse's aide. So to answer your question, we're low and we need to improve that. And thank you for the question.
And one other question came in. I'm wondering if David could speak to the lack of providers for mental health in facilities. Many providers report that the reimbursement is such a struggle, it's not sustainable. And then also facilities often report lack of funds for the care that's needed. Is this because reimbursement rates are too low?
You get me with 2 minutes before the break on that question, Kathy?
I didn't ask it. Somebody
I
else.
know. Well, let me begin by appreciating the question. I think the issue associated with reimbursement and reimbursement for mental health services is a big issue. And I do think that it is important. I mean, again, in California, for example, this facility that I've been involved with monitoring welcomed these individuals. They were getting special rates to bring in this type of population, younger with mental health issues, homeless. And so they had an incentive to take individuals in. And so that was a challenge, a financial incentive to do that. And so, that's the bad side of things when you just incentivize people and don't deliver care. And it's equally as bad as when you don't pay people for delivery of needed services. So I think it's worth a further discussion as to how we reimburse for mental health care.
Great. Thank you, sir, very much.
My pleasure.
We will take a break now. Again, go back to your email that you originally got so that you can then connect to the links to for the workshop that you'd like to attend, and they will start promptly at 10:30. Thank you again, everyone. Enjoy the rest of your day. I hope you learned something today and that this new way of doing our conference, our symposium, wasn't too difficult. I certainly enjoyed the speakers that I was able to listen to and to interact and ask questions. So again, a thanks to all of our speakers and all of those that helped out in putting that together. I particularly want to thank Holly Tuttle, who works for our agency and was the spearheader of putting this all together and worked very closely with Damon in making sure that this happened. So a special shout out to Holly. Just a reminder that you need to complete, you've heard this like 8 times today, but we're going to do it again. Complete the evaluation form found at the bottom of your email that you got with all the contact information. Just to remember that a recording of the sessions will be made available on the community college's YouTube page, as well as PowerPoints of the session on the community college website. It will probably take a week or so to access that information, as well as then it'll take a couple weeks to get your certificates as well. So again, my sincere thanks to all of you. I do miss our closing session where we have the basket raffles. It's too bad we didn't think about a way to do that virtually, but we'll think about that if we need to do it again this way next year. But I look forward to all of you returning for our 18th annual symposium. And my again, thanks for your participation, and I wish you the very best, and please be well and safe. Thank you again for joining us.